That's didn't remind me to record. All right. So battle signs. What do we call bruising around the eyes?
Raccoon eyes.
Raccoon eyes. Raccoon sign. All right. Confused, blurry vision. Yeah, eye disturbances or visual disturbances. All right. What else? Oh, so other things that you could also see besides nausea, vomiting, dizziness, lightheadedness. Vomiting with a brain injury can also cause projectile vomiting. In other words, they can hit a target like 5 feet away. So it's straight shot instead of straight down. There's another one. Oh, altered behavior. They can be combative. They can be forgetful. So with the primary injury, that's direct trauma to the brain. Whether it be a penetrating wound, whether it be acceleration, deacceleration, whether it's a baseball bat to the head, whatever it is. And then a second injury would be what's happening as a result of that trauma. So if the person is hypotensive, if they're breathing too much, if they're retaining too much carbon dioxide, if it's too hot, if their blood sugar is too high, that's going to cause additional damage to the brain. Do you think the brain will really like you hurting it even more?
No.
No. So we have to make sure we don't hyperoxygenate the patient, that we have an airway, that their pulse, blood pressure is okay. If it starts going up, then that is cause for concern. And we'll talk about Cushing's in a little bit. Oh, another thing they can have is seizures. Remember the ALU tips? So one of the causes of seizures and ultramental status is trauma. That's why you have to rule out trauma. If you can't, then figure out how long ago it was. All right.
Stop that yawning, Lou.
I can't help it. I couldn't sleep. So remember earlier I talked about the foramen magnum?
Yeah.
All right. So we talked about that big hole. So we know that traumatized tissue swells. So if we have increased pressure in the brain, eventually, and it depends on which part of the brain, eventually that brain can be pushed through an opening, the foramen magnum, for example. So what do you think is going to happen to body function as a result of that trauma?
There won't be no body function.
What was that?
There won't be no body function.
Well, yeah, there could be no body function. There could be inhibited body function.
A herniation?
Yeah, that's with their herniation, where they can become, they can go in a vegetative state.
Yeah.
They remain in a coma. I told you about that kid that went head first into the Rock Hill.
Yeah. Yeah.
So he had both a herniation and a diffuse axonal injury. So something is causing the issue. Okay. So Sequoia can't see me yawning.
It's contagious.
I saw that yawn.
No.
Liar. Your puppy's giving you away.
No, he was digging his claws into me.
All right. So signs and symptoms of a herniation can be altered mental status, weakness, paralysis, altered respirations, um, posturing. Have we talked about posturing?
Yes.
Very briefly.
Okay. What posturing is, and we talked about it with GCS back in neurological, is that we apply a painful stimulus. Right? Remember motor function? Spontaneous, localizes withdrawals, flexion and extension. So what posturing is that flexion or extension, also called decorticate or decerebrate posturing. So with decorticate, what happens when you apply painful stimulus, what they do is they bring in, and this is the flexion, is they bring in the arms and it kind of looks like a T. And so that's the way to remember decorticate, is they're creating that T with their arms. Whereas with the cerebrate, that's extension. So when you apply painful stimulus, you'll see the arms go and kind of uh, extend out. So that's posturing. We don't want to see posturing on our patients. If we do, that is a bad sign. The last thing you have on there is Cushing's reflex, or what we call Cushing's triad, which says that the blood pressure is going to become elevated. But more specifically, you're going to have what we call a widened pulse pressure. What does that mean?
Increase of blood pressure or the
Yeah, we're going to have an increase in the blood pressure, but specifically, it's going to be the pulse pressure that's going to increase. What does pulse pressure mean here?
The difference between the systolic and diastolic pressure.
There you go. The difference between the systolic and diastolic is getting further and further apart. So you could have 200 over 100. So that's the first component. The second component of Cushing's is normal to decreased pulse rate. And then you'll have, and the newer books are talking about an abnormal respiratory pattern, usually buyouts or Cheyne-Stokes. But the third one that I learned is actually decreased respiratory rate. just to let you know, I love testing on Cushing's. All right, so we talked about open and closed. So that fused axonal injury that I was talking about is where there's a shearing, tearing, or stretching of the nerve fibers within the brain and the spinal cord. So a patient can go into what we call a vegetative state as a result of that injury. Because remember, traumatized tissue swells. If you have shearing or tearing of the nerve fibers, how well are those signals going to be communicated down the line?
Not well.
Not very well. And so, I forgot what I was going to say. All right. Why is this a close to injury?
Because the skull is still intact.
There you go. The skull is still intact. So, Marcus, what is our concern with this particular injury?
Well, it depends on the mechanism of injury, but from that, it just looks like just bleeding and preventing infection.
Okay, but there's something else. So right now, bleeding is controlled. What are three concerns with this type of injury?
Well, they could have injured looks close to the brainstem, so it could be some swelling.
Okay. What else?
Would you say that it's not too far from the artery?
No, I can't say that because I don't know. But is that a consideration to think about?
I would think so.
Yeah. Okay. What
And
else?
he could have suffered a concussion.
Okay. Loss of consciousness, motor function loss. What else? So one of the three I was looking for would be a lacerated artery or vein. What's another concern?
Infection?
Okay. But I think these other two take a bigger, whatchamacallit. Mr. Abraham, what do you think?
A skull fracture?
Okay. We may have it.
Intracranial.
But we talked about this on Thursday, on Wednesday. Bruising the brain, maybe, What about an air embolus? What about subcutaneous emphysema? So those are the other two I was looking for. Think about what else. You have an open neck, upper neck gash, and air can get in there. So how would we treat that closed head injury?
An occlusive dressing,
Tape
tape
down on how many sides?
on all four.
On all four.
3.
Now this one is 4. Remember, 3 is for the chest because we want to let air out. In this case, we don't want to let air out because it's not going to happen. So just occlusive dressing, tape down on 3 sides. What about this one?
It's an open skull fracture.
Yep, open skull fracture. You see the intracranial hemorrhage. Well, intracranial hemorrhage would be within the cranium, so more of the brain, between the brain and the skull. Yeah, you could have intracranial bleeding with this. So you see the thickness of the scalp?
Yeah.
Yeah.
So yeah, we definitely want to consider preventing infection. Might consider putting some gauze in there, sterile gauze, and then badging it down. Keep an eye. This actually, now I just realized where it's at. Here's his ear. So this is happening like right about here, where the fingers on the right hand are. That's the forehead. Has anybody ever suffered a concussion?
Yeah.
Me.
Did we already talk about this?
About concussion?
Yeah.
You kind of briefly went over it, but didn't really.
Yeah.
All right. So if I briefly went over it, what did I say about a concussion? So it's a mild diffuse axonal injury. Remember, it's an injury that happens to the brain. Usually, when it happens, people will see stars, and the patient can be confused or altered or unresponsive as a result of that concussion. Usually precipitated by some sort of head injury. So if Sequoia hits me upside the head with a baseball bat because I keep yawning, she can cuss me.
Okay, you won't remember a thing though.
True, but it's recorded, so I'll have that as a memory jogger. And you have to find out where I live to come into my house and be able to alter the recording. They can have lingering effects, post-concussion syndrome. That would be from a headache, confusion. They feel dizzy, lightheaded, nauseous. It's something that stays for a few days while they're getting over that. Prolonged blows to the head can cause damage to the brain itself. If you've seen any of those movies that deal with head injuries to football players mainly, but soccer players will also suffer issues as a result.
What about boxing?
Boxing is very common for concussions, yes, because it's that punch. So Sequoia, instead of using her baseball bat, she punched me. She cold cocked me.
Is that why you got cauliflower ears?
What is cauliflower?
I don't know what it, but it's like your air explodes. It's like so much pressure that your air explodes.
Yes.
No, well, it's a deformity of the ear, because blood like collects in the outer the outer ear or whatever.
Yeah, it's what is it, the tinna, the outer ear. What happens is they break it and it does bleed and it becomes deformed as a result of that injury. So that's what it is. All right. Contusion, a bruise on the brain, directly on the head. You could also have it from coup contre coup. You have the bruise in the front and the back of the brain. Now, because it is bleeding, pressure can build up as well. And the brain, having been traumatized, can swell up. All right. Subdural hematoma, as we mentioned, that's bleeding that's occurring under the dura mater. It is a slow bleed because it's affecting the veins, as we said. Now, what happens, just like any other type of bleeding, even with the epidural or the subarachnoid, is, again, as that blood starts to accumulate, it's going to be putting pressure on the brain. We don't want that. If we have what we call increased intracranial pressure, what are we going to see the patient start to do?
Grab the
Elevated.
What's elevated?
The blood pressure and decreased heart rate.
Okay, what do we call that?
Crushing reflex.
Not crushing,
Or
Cushing's.
Cushing, my bad.
Yep. Cushing's triad or Cushing's reflex. One of the history things on bleeds is find out how long ago this occurred. Because if it's been going on for several hours, what kind of bleeding do you think it is? Arterial or venous?
It's venous.
It is venous. All right. All right. So here it'll show you a subdural. It's underneath. You see the pressure that blood is, that accumulating blood is putting upon the brain.
Yeah.
Yeah.
Okay. Now, remember I told you when you guys were taking me up and down the stairs, what did I tell you guys about me? Anybody remember?
If we drop you to quickly call the ambulance
That you'll have to call the ambulance for me. Why?
because you're on blood thinners.
Yes. If there is a bleed and the person is on blood thinners, aspirin, Plavix, Coumadin, any of those blood thinners, and there's others, Eliquis, they're going to bleed longer because they don't have the clotting ability or the quick clotting ability. So you need to ask what medicines they're on. And so the elderly, middle-aged and elderly, they could be on those blood thinners. So make sure you ask. Um, okay. All right, epidural hematoma. So an epidural hematoma, it is rare, but it's extremely critical. One of the things about the epidural hematoma is that it's usually a arterial bleed. So what does that mean?
Bleeds faster.
It's going to be bleed faster. So how quickly are you going to start seeing signs and symptoms of that epidural hematoma?
It's a rapid onset.
Rapid onset. Now, the other thing with epidural hematoma is patients have what they call a lucid interval. Who can I call on? So, Ashley, what do we mean with a lucid interval?
Sorry, I was sneezing. Is it like, I guess where they can comprehend and everything's like normal for better, like lack of better words?
Okay. So, what does that indicate?
That like, um, that like they are in a state of like confusion, I guess.
Yeah, they could be unresponsive, unconscious, or very altered at the beginning, and then they wake up like nothing happened, but then later on they're going to go unconscious again.
Yeah. Okay.
So that's a lucid interval. Liam Neeson, you guys are familiar with Liam Neeson? The dad from Taken?
Yeah.
Or for you Star Wars fans, Queen John Ung or whatever his name is. I can never pronounce it. Remember him in Star Wars?
Yes.
Okay. His wife. He's actually a widow. His wife, Natasha Richardson, she was out skiing up in Canada. And she crashed into a tree. Al, She went through a lucid interval as they were taking her to the hospital. She went unresponsive again. As a result of that head injury, she died because of the arterial bleed. Plus, the hospital wasn't very close. They had to take her a long way for that hospital. It is a faster bleed characterized by that lucid interval. So you want to look at the signs, and earlier we were talking about the unequal pupils. We were looking at ultramental status, but late sign, and this is a big one, and I'm trying to remember if I mentioned this to you guys. A late sign would be fixed and dilated pupils. What does that indicate? It even talks about absent reflexes. So what do you think is going on in order to cause that? What can I pick on? Damn, isn't it quiet without Paul here?
Yeah.
Yeah.
Yeah, they don't have anybody to pick on today.
Well, we can pick on you, Luis, or I can.
Oh Lord, I should have just stayed quiet.
That's okay. Remember, she's been picking on me about yawning and everything. I don't know. I think she's trying to like not be defensive, but be like trying to play it off like
Well, maybe just because I'm
projecting. Huh?
maybe because I'm hungover.
Whose fault is that?
Rosie's. It's definitely Rosie's.
Yeah, blame someone that can't defend themselves. I don't think she forced those drinks down your throat, though, young lady.
Mm-hmm.
So, since Paul's not here to pick on, I'm going to pick on Sequoia. I'll take the heat for you, Luis. I got you, Tocayo.
All right.
It's the quiet ones you got to worry about, Lou. Luis is not innocent as he thinks he is.
Do you think you're
No
telling
comment.
this Luis anything about that Luis that we don't already share?
Yeah, that's
Trust
true.
me. He's not quiet. Not quiet.
So, Ms. Sequoia, so what's happening in order to have fixed dilated pupils and decreased reflexes or absent reflexes?
Say that again?
So your patient is presenting with fixed and dilated pupils and absent reflexes. So what is that indicating to us other than, oh shit?
Possibly shock?
Well, we have spinal shock, neurogenic shock, but it's worse than that.
I'm not sure.
They're dying.
Expand on that comment.
Are we still talking about the epidural hematoma?
Yep.
Oh. Well, it says that only about 6% or like 2% or something it requires like hospitalization, but
Yeah, because they usually die.
yeah, because they're having a lot of blood loss.
Uh-huh. And compression on the brain, reducing blood flow to other vital areas of the brain. So as a result, you have severe dysfunction to very minimal brain activity as a result. That's why fixed and dilated pupils. When else do you see fixed and dilated pupils? When somebody is dead. You shine the light, they don't react. They're dead. Absent reflexes, again, there's minimal brain activity to cause reflexes. So I just want you guys to picture why the patient would present in a late sign, obviously. The more damage occurs to the brain, the more anoxic it becomes, the more issues you're going to have. Now, what I meant with anoxic, it means absence of oxygen to the body. I don't even mean hypoxia. I mean anoxia, where the brain was not receiving any oxygen. And so a person can receive what we call an anoxic brain injury. So somebody in cardiac arrest, if they were down long enough, they could suffer an anoxic brain injury because of the lack of oxygen flow to the brain. It causes severe brain damage. Okay. So same thing here, and look at that meningeal artery. Dang, we ruptured that bitch, and we got that hematoma right there. So the epidural hematoma. You notice there's a meninge right there. There's the skull. There's no meninge here, so the blood is outside of the dura mater. All right, I showed you a couple lacerations. But what caused that laceration? That's what we have to think about. Whenever we have a head injury, we always have to think about the possibility of the brain being affected and the spinal cord being affected. Going back to what I said when we started trauma, you kind of have to be a psychic. I'm going to be thinking about the brain and the spinal cord. Just think about it. Although we're talking about the brain right now, did I tell you the one about the dude with the fractured jaw?
No.
No.
So we got called out to transport a guy from one ER to another ER. He was basically going from a private hospital to a public hospital. They'd stabilize him, so they're like, okay, he's good to transport. So I let my partner, EMT, go in the back. I'm driving, and then he says, Lou, he's starting to complain of numbness and tingling down his arms. What do you think my response was?
Oh, crap.
Well, I used a different word, but yeah. Same effect. So tell him put him to C-spine him. So he puts him on a short board, immobilize the back. He was, I think, riding his bicycle or his skateboard. He fell down, landed on the street or on the curb, and landed on his jaw, breaking his jaw. As I said about anticipating other injuries, think about the amount of force required to break the jaw. So is that sufficient force to cause a spinal cord injury or even a brain injury?
Yeah.
Yes.
Yeah.
It's like being punched in the face, like with your nose breaking. It can go into your
Oh, like the action movies where they take the heel and they go up
Yeah.
on the nose and it shows the nose into the brain?
Yeah.
Yep. So what sign is most consistent with a concussion?
Sensitive to light.
Was that? Did you say D?
That works.
Damn, Luis, you're on top of it.
Stop giving him credit, Lou.
I'm not. He answered correctly.
No, he didn't. I didn't hear anything.
You're deaf. You're hungover. What do you know? So in our assessment, we have to look at the mechanism of injury. What happened? And again, think about what other injuries could be occurring. Get the medical history. You guys are learning sample, but just keep in the back of your mind that when we get out there, we don't really do sample. What we're going to do is history, allergies, and medications. Look at the age. You're an elderly person, you got to think about more issues, more meds. Whereas a young person like Sequoia and Rosie get into it.
Nah, I don't think that happened.
Oh, it's going to happen. Just watch.
Nope.
I wonder who would take more of a beating.
Well, Rosie's scrappy, but Sequoia is taller. So I think it'd come out even.
Yeah, probably.
You don't know me like that, Lou.
Are you telling us you're a wuss? I don't see that. Keep an eye on your patient. So look at the mechanism. The one patient I could remember, her and her husband were riding an ATV, and here comes a car, and they hit the car. Now, somebody was doing 70 miles an hour. I don't remember who it was, but she hit head first into the door. And so put her in C-spine and transport her to the hospital. Now, you have to get the mentation level. Remember, you want to do a lot of things baseline, so you have something to compare it to. So, ANO times what? ANO times 4, 3, 2, whatever it is. So you know what the baseline is. This particular lady, woman, whatever, she was like in her mid to late 20s, married. And so she was an ANO times 4. But to make sure in my reassessment, I told her to say, or to tell me my name. I told her my name. Which in Spanish, everybody that speaks Spanish, when they hear my first and middle name, they kind of chuckle. All right. But my name is Luis Miguel. So that's exactly what she did when I told her my name was Luis Miguel. And she chuckled. So I said, every so often, I'm going to ask you what my name is and just let me know. Okay. And so every time I asked her, she'd chuckle and she'd be like, Luis Miguel. And okay. Well, eventually what started happening, this is another sign of a head injury, is repetitive questioning. When they keep asking you, pretty much asking you the same thing over and over, that's called repetitive questioning. So, indicative of a head injury? Yeah.
Yes.
Yeah.
And then I asked her my name, and she struggled remembering my name. More indication of a head injury?
Yeah.
Yes.
Yes. So, when you assess, get that baseline set of vitals. If they're unresponsive, do a very quick head to toe. Remember, you always want to rule out trauma before you move on to medical. Although, if they're outside, here's another dude that he'd been drinking, and then you know what I've said about he's been drinking stories. He's riding along, except he doesn't have very good coordination, and he goes off the side of the road. He fucking does an Evel Knievel, except he doesn't make it over the pile of logs. So he comes down, it hits, the ATV hits the logs, he gets launched, and he's over the next pile like 10 feet away. Needless to say, this guy wasn't very conscious. So, head injury?
Yeah.
Oh, yeah. Yeah, we ended up flying him out. You could see the trauma. If you see a dude, I'm not going to give away too much because you guys might still do this one, but if you see a dude on the outside that appears to be intoxicated, Frankie, Are you going to think they're intoxicated?
Nope. Or you can assume.
You can't assume it.
What do they reek of alcohol?
You still can assume.
Okay. Especially if it's a driver that they suspect of DUI. And you're there assessing him, and you tell the cop, yeah, he's been drinking. So he gets arrested for DWI. And so when he has his day in court, what do you think the defense attorney is going to do?
Point out that you told the officers that he was reeking of alcohol.
And that he was intoxicated.
Yeah.
So what the defense attorney is going to do, okay, Mr. Silva, so what are your qualifications to determine that somebody's intoxicated?
Don't have no qualifications, sir.
Okay. So you just assumed that my client was under the influence.
Correct. You win. Sorry.
Yep, charges dropped. So I have a reason for it. Would this be an indication of a head injury?
Yeah.
What if you have blood and hairs? More reason to, right?
Yeah, for
What if
sure.
there's a hole?
Even more.
Yeah, even an ejection. So here you have other mechanisms. We talked about the vehicle crashes. There's Sequoia beating me upside the head. There's Sequoia hungover trying to do some housework.
And Sequoia versus Rosie.
I was gonna say that.
Gonna happen.
It will. Just wait.
Nope.
It's gonna happen.
Nope.
So we have to be careful about oxygenating them because we don't want them to suffer any further injury to the brain as a result of all that oxygen. If Rosie texts you, don't believe it.
Why, Lou?
No reason, because we have to hold C-spine right here. Remember, if we had that head injury, so we have to think about the brain, but we have to think about the spinal cord as well. So, C-spine, remember the priorities, ABCs? And C-spine is a priority in this case. What's our issue here?
Laceration to the face and bleeding.
Multiple lacerations to the face. Is this going to cause an airway issue?
Yes.
Yeah.
Does his nostril already look swollen shut?
Yeah.
Who knows what the other side looks like? So you might have difficulty inserting an MPA. Well, what about an OPA? But then would this make it harder to ventilate with a BVM?
Yeah.
Yes.
Yep. So you have the airway issues to consider.
Why is there tape on the eyelid?
To keep the eyes closed so they don't open up. But he's most likely knocked out. All right, we've covered GCS before, haven't we?
Yeah.
You know what? I might do that. As part of your quiz tomorrow. No, you got an exam tomorrow. Dang it. Wednesday, I'll do that. Okay. We've talked about depressed skull fractures, open fractures, penetrating fractures, checking pupils. There's that drainage I was talking about. So what would you do to this blood? Dab it. Dab it with a 4x4. Do the halo test. Although I don't know how you could do motor function on an unconscious dude, but you could try. Is there anything in there that we haven't talked about?
No, not really.
All right. I just want to make sure that we cover. I know it's 12 o'clock. I want to make sure you guys feel comfortable with a head injury. Really, it's the type of emergencies that we covered at the beginning. The rest of it, it's pretty much the same treatment. You want to protect C-spine, protect the airway. Remember, they're altered, so they might not be able to protect their own airway. Ventilate if necessary. Do pulse ox. Don't hyperventilate a patient. Hyperoxygenate them. Assess their mentation and reassess their mentation. Ask them any nausea. They feel like vomiting. Did they vomit prior? Blurred vision. Any seizures? Upon arrival, if somebody's around, ask a bystander, did they lose consciousness? Because that could indicate that lucid interval. Remember Cushing's triad? Your patient may be a little bit hypertensive to begin with. However, as long as that widened pulse pressure doesn't present itself. And then you also see it with, as long as the pulse rate doesn't go down. Anything else?
Nope.
Not really.
No, sir.
Is everybody happy?
Yes, sir.
Yes, sir.
Liars. It's Monday. People aren't happy on Mondays. Well, there's a reason to be happy on Mondays, but I doubt it. Miss Sequoia, what the hell are you doing back in bed?
I
Looks
want to go to
happy.
sleep.
Miss Princess right there in her big ass bed.